Wonderful. Can you all see on the Zoom, people? It sounds like this. So thank you very much. Thank you for organizing, Sherry. And thank you, Steve. This is a fantastic meeting, I have to say. This is very timely in my area of interest. I have been consistently funded by NIMH for my work on depression and by NIDA on my work in methamphetamine. And I have a strong interest in finding out how the two are related and have not been funded by any institute. Part maybe because my grants have not been good, but I have to imagine part of it is we have not really understood what the relationship is. So this is absolutely fantastic. So thank you for organizing this, Steve. I think we have to begin to be more multidisciplinary in our understanding. We'll have to understand the mechanisms associated with it before somebody is going to give us an idea of how to fund it and how to study it, because we are not making a difference in both, actually, unfortunately. And so this is very timely. And then from the pandemic, we're beginning to get together so that I don't end up doing this too many times. And Steve obviously has the power to get a lot of people together. Although it reminds me of something I heard. There is this guy who was invited, who is an expert in an area, and he is invited with some reluctance. He agrees to go because it was outside of Atlanta, 2-hour drive from Atlanta. So he packs his bags, goes there, drives 2 hours, is excited, but there's not too many people in the audience. There's 3 people in the audience. So they're waiting. They wait and to see if more people come in before they start. Finally, the 3 people in the audience say, "Why don't you go ahead?" So he starts presenting and is very animated, finishes his presentation, packs his stuff, puts it in his briefcase, and starts walking out the room because he has to drive 2 hours to get his flight from Atlanta. So the other 3 people say, "Where are you going?" And he says, "Well, I have to go back." He says, "We've waited in the room to listen to you. Now you're going to have to wait to listen to me." So so as we are getting together, we are going to have to learn how to do this together. So it is very clear that there is an increased risk of both physical and psychiatric illnesses associated with it. You've talked about HIV and cardiovascular and pulmonary arterial hypertension, but a number of other things. There is a higher risk for psychiatric illnesses. Fatigue and hedonia are very commonly presented. And the timing and how to look at it, whether it is immediately after the use, is it 2 days after stopping methamphetamine, it's 2 months after, that kind of sort of timeline issues are also need to be sorted out. And social problems are clearly evident with methamphetamine use. The one thing to remember is the methamphetamine, unlike actually just pure amphetamines, is more lipophilic, and it does seem to have, therefore, a greater penetration in the CNS and longer duration of action, which may account for its higher addiction potential. It does release monoamine neurotransmitters from nerve endings. There is decreased monoamine reuptake and enzyme degradation. There's rapid and sustained increase in extracellular monoamines. And the cardiovascular action we heard already. So more of that needs to be understood, but how that then relates to sustaining meth use is something. The acute effects are interesting, and I think we should be understanding and trying to talk about it. But I think the majority of the problem that we have to really get a better understanding so that we can improve interventions. As Steve mentioned, actually, we just completed a large multi-center trial that is the first ever positive trial of any magnitude for methamphetamine use using a pharmacological intervention. So we have really drawn blanks until now because we've not understood the mechanisms. And so chronic use of methamphetamine is where we have to really start impacting, because that's when patients come to us. They don't come to us after having tried methamphetamine one time, say, now come and help me get rid of this methamphetamine. So the chronic use is really where there is damage to both dopamine and serotonin nerve terminals. The doses, as was already mentioned, are much higher than the amphetamines that are prescribed. Although I think some more discussion toward in the end may be worthwhile looking at because I heard some of the impact of even therapeutic doses of amphetamines on endothelial cells, and I think that may be worth thinking about. The hypofunction actually is affected, and we know about that in the dopamine reward circuits, and that is maybe directly related to depression. We don't know, but that is something worth thinking about. And these are really effects are dose dependent in our patients, as was noticed again. They end up increasing the frequency and the route of administration, so we'll have to figure that out. There are downstream effects in terms of oxidative stress, neuroinflammation, and excitatory neurotoxicity. The effects are seen not only in dopamine, but also across many neurotransmitters and also the HP axis. And then there's this hyperthermia associated with methamphetamine can also lead to excitotoxicity. Impairments as observed, and this is very well done studies now show about 40% of meth users actually have clear abnormalities if you do neuropsych testing in terms of memory, motor function, maladaptive reward circuit related functioning. So you can do reward tasks. Impaired executive function can also lead to other things, including perseverative behaviors, irritability, etc. Usually, that thankfully doesn't lead to gross movement disorders like Parkinson's, but can have impaired fine motor dexterity. And then the psychiatric symptoms are often very commonly associated throughout the use of methamphetamine, including during the period of withdrawal and abstinence. And irritability, anger. And one of my colleagues, Manish Jha, is here. He's been doing a lot of work on irritability associated with not only with depression, but also with suicidality. And so that is the other aspect to consider. These methamphetamine effects on psychosis, I won't go into too much detail, but they are also well known, as you all know. When you compare patients who have meth use, this is from a study in Australia with 400 participants, and you can see that most people entering treatment programs with methamphetamine have high levels of depression that actually require clinical management. But to be very honest, I don't think we know exactly what interventions to use for that group of patients. There's not good enough randomized controlled trial data showing that traditional antidepressant treatments for that, like SSRIs, SNRIs, are really that profoundly effective. So what exactly to do for that group is not totally clear, not as much has been studied, and as I mentioned, as lamented earlier, maybe I was just whining, but funding for the comorbidity has been a big challenge because the peer reviewers really get stuck. If you go to NIMH, then the peer reviewers have a really hard time figuring out how best to understand the role of methamphetamine and the timing of this depression. And you go to a NIDA, then the depression becomes another issue. As I mentioned, methamphetamine-induced psychosis really mimics very similar to schizophrenic presentations, but it can lead to chronic psychosis. And then you may have to treat, and most of the case reports, because not, again, randomized trials, but case reports do seem to suggest that atypical antipsychotics might be sufficient for that. Methamphetamine modulation does affect dopamine circuits, and I'm not going to go into too much detail, but I was intrigued about how much of this vascular effects that we've been talking about with pulmonary arterial hypertension mimics with the effects in the brain, and then how that affects the blood-brain barrier would be wonderful to study. And I think even in your cohort, Steve, and the Stanford group, I think how much of and what particular aspects of functional neuroimaging you are able to capture may be helpful, especially looking at the blood-brain barrier, because as you're looking into neuroinflammation, it may be the changes in the blood-brain barrier that is actually what is driving a little bit of that. And then some of the other things you all are very familiar with, meth-associated heart failure hospitalizations are really on the increase in the United States, and and the West Coast is really far ahead of everyone in a lot of exciting things, but sometimes you drive. So this is now moving to the rest of the country. Methamphetamine is so, yes, sir.
Can I have a question? I missed the opiates there. How are opiates compared to stimulants when it comes to heart failure hospitalizations?
I am not as familiar with that. Anybody in the audience know about it?
The reason I ask is that usually when we talk to our East Coast, again, they are not seeing much meth yet, but they certainly seem impressed and a little bit skeptic about when we talk about that because they see more opiates. Anyway, I was just curious.
Yeah. On the other hand, we just launched several big methamphetamine and cocaine, but methamphetamine trials. And we are now identifying sites in the Northeast because their rate of meth use is increasing. So that is another sort of drug use, drug addiction world that we have to talk about separately, in the sense that we have paid so much attention on prescription opioids as if that was the cause of addiction. But people who are at risk for drug use figure out a way and a source, and it doesn't depend on a physician prescribing. But that's my bias, and before Steve kicks me out, I'll move on to
we have no market, there's no data in the country that says on how many days out of the month somebody.
And fortunately, Steve and we just launched launching a large trial looking at that very population, but we have to be careful because it's a randomized trial. So it's not active opioid use, but people who have consistently used opioids before they get randomized is the population we're beginning to study. So at least we'll get a little bit of a sense. The other is methamphetamine leads to strokes, but also in young adults. And so this is something that you probably all see it also quite common, and they are hemorrhagic strokes. So in my sense is, I think we are at a very good point. This is a very timely conversation, Steve. I can go into all the details about other neuropsychiatric illnesses and mainly how best to think about depression. But my plea to all of us and to you, all of you are already starting, is to really get a better sense of the mechanisms associated with neuroinflammation that lead to either depression, anxiety, or other symptoms, and similarly for vasculature effects, so that we can figure out when and how to intervene in populations that patients don't actually come in isolated with one methamphetamine or psychiatric illnesses. They have both actually most often. And so we need to think about that. I am going to stop here.